back to my channel. My name is Nia Ayin, and today I'm going to be talking about being a patient care associate. So some other names for this are CNA, Certified Nurse Assistant, or STNA. That's what we have in the state of Ohio. And usually CNAs and STNAs work in skilled nursing facilities or nursing homes, but in the hospital setting where I work, there's a little bit more duties and it's a little different, a little nuanced. It's called Patient Care Associate. If you'd like to learn more about it, just stick around and hit that like and subscribe button and leave some comments below. So basically, let's just get into this. Patient Care Associate, the roles, the general, I like to put them into like some broad categories when I'm training. So we have that you're responsible for vitals, you're responsible for I's and O's, which is your input and output of all fluids, and then your labs. And so that's kind of how I categorize the main things. And then patient care associate, the patient care part, helping people with their ADLs, helping people with baths, with feeding. You're a support system person, and so you're working with the nurse or underneath of the nurse under their license, basically, to do your job. So I just kind of briefly said it, but I'll say it again. The patient care associate role, at least where I live, is an unlicensed personnel that is helping on the nursing staff. And so get trained on EKGs, on drawing regular blood labs, no ABGs, which is the arterial blood gas. You wouldn't be doing that. That's a respiratory role. But you will take their vitals and you will do like eating labs, or if they have a H&H ordered or a PTT, or I will just put those words up too so you can learn them. But I think it's good to like start to learn the jargon and the acronyms pretty early in nursing, because it seems like in nursing and medicine in general, anywhere that you go, there's a lot of acronyms, and so just like to try to use them in daily conversation to kind of make them more easy to use. So when you're working in a hospital setting and versus a skilled nursing facility or nursing home, or an outpatient facility, things are a little bit different because each unit has its own specialty, and so the patient population is going to change, and that's going to change your experience when you go to work. And so the different places that you can work as a float pool person where I am employed are the ED, the ICUs, there are several, the Med-Surg units, and then the PCUs, which are like a step down ICU, which I'm including in ICUs because as far as your experience as a patient care associate, it's pretty similar. And then there's the rehab facilities, and then there's maternity. That's the one place I've never been that I really want to go to, but it's okay. I will have my time. I will go there, I'm sure. Roles. So in the emergency department where I work, because it's a level 1 trauma center, there's different areas that you can work in. And so the main area that you work in would be either triage or in the psych units. In the triage area, you're just doing vitals on all the patients, and they all have different levels of acuity, which is how severe is their illness that they came in for. And so you'll be checking on them. Excuse like the highlighter that's on me. I was studying today and I just got messy. But anyways, what was I saying? I apologize. Based on the level of acuity, you'll be doing vitals pretty much the whole time that you're assigned over there. You will also be drawing people's labs and getting EKGs done. So you'll be bringing people into a side room, grabbing their temperature, blood pressure, etc., ask them how they're doing. If there's something that you observe that is changing with the patient that seems really, really severe, and you think that you need to let somebody know, let somebody know. Like, you're doing their vitals. If there's any critical values that you see, it's your responsibility to pass it on. It's not that some people think, I believe, you put something into the computer system and then it just will alert the right person or the right higher up that's supposed to deal with this patient. That's not true. You need to be vocal and to be you're a support system person, and you have a large responsibility to be a good communicator as a patient care associate. So as soon as you see a critical value, if you don't know what critical values are, you should be like having a piece of paper with you until you have memorized them. After you get a feel of working for a while, you get a sense of what is urgent and what's not so urgent, and I wouldn't try to make a call on what's urgent or not so urgent until you're 100% sure. But at the same time, if you're not sure, there's so many people around you that you're working with that you can ask, and that's what I like about being in float pool. And so that's the triage area of the ED. The other area of the ED that you can go to as a float pool person where I work is the psych unit. Now there are multiple psych units kind of, and actually there's more than just those two areas, so I'm going to cover more areas of the emergency department and how you can work as a PCA there and how your workflow will change. But basically in the psych area, you can be getting labs and vitals on people, but you have to be aware that they are coming in with some sort of psych history, and so they're there to be evaluated for not a physical ailment but a mental ailment. And so your emotional intelligence has to be on 10 basically, because the way that you react to this person or the way that you interact with this person is going to set the tone for their experience. And if they're going through a trauma, or if they're not in their right mind, they're not even oriented to time and space, it could be a really bad experience for them and then for all the other people around you. So you have to have a really high emotional intelligence and patience to work with the psych patients that come into the emergency department, because this is maybe the worst day of their entire life, or their worst state that their mind has ever been in when they show up at the emergency department. So they're not going to be upstanding citizens when they walk in. They're going to be at their lowest point, and so you have to kind of remember that that's where someone is and that their frustration level is at that point already. So many things have occurred before they showed up at the ED, and now they're sitting there and they're waiting to be evaluated, and you're with them in this room making sure that they have what they need while they're waiting. It's not a lot that you can do, but the little things that you can do make a big difference to these people. And a lot of times I see like alcohol withdrawal and drug abuse come through, and that falls under the category of psych evaluation at the hospital. If someone's having suicidal ideation, they're coming straight there. So like you're one of the first people they're going to see when they're feeling like this. So you have to be outside of yourself and ready to be there. You have to give a lot of energy emotionally. Another area of the emergency department that you can work in is the observation unit. So sometimes patients need more observation. They need more tests to be done before the doctor can decide if they need to be admitted or they can go home. And so I think this exists in a lot of hospitals. Have patients with like history of heart failure or stroke, and so you're trying to see like if this situation that they're coming in for today requires an admission. And so that means that they're gonna have CT scans, x-rays, more labs. Sometimes, this is so sad, but during the holidays people like to, you know, fry turkeys in like really deep deep like fryers. And if you do that in your garage and you don't have great circulation in your home, you can get carbon monoxide poison. And because we don't have carbon monoxide detectors in our bodies, there's not a way for your body to respond to it quickly. There's going to be more damage done to your body by the time that you realize that you're being poisoned by carbon monoxide. So you might have headaches. It's a huge danger, and I have seen in that observation unit patients come in because they were just they were trying to cook a holiday meal and they weren't doing it in a safe way at home in an enclosed area, and they got carbon monoxide poison and they had to go to the hyperbaric chamber. And so the hyperbaric chamber is another area where the patients will go to get rehabilitated from having unfortunately experienced that. And so those patients will also be in the observation unit. I think I covered all of that. And then like the other area, of course, in the ICU, or not ICU, in the emergency department at a level 1 trauma center is the trauma area. So if you are an EMT or you have an EMT background, or you are specifically trained in the emergency department to deal with traumas, that you can go and help out. I've definitely been excited to be in those before. Everything's happening so fast, and you have to be a really good communicator, as well as keep your eyes open, because you don't know what you're gonna see. Nobody knows. And so you have to be in the right place at the right time, basically, and really get your hands in there and not be shy. You cannot be shy in a trauma. And that is something that you can do in other units a little bit more. you have to be very vocal and you have to be very confident, I guess you could say. You have to be confident all the time, but when you're dealing with a situation that you may have never seen before and you may never see again, specific types of wounds and falls, especially in a level 1 trauma center, and you really have to stay focused on why you're there. Your role as a patient care tech or a patient care associate in that situation is very similar. You're going to get glucose reading, you're going to get the vitals, and then you're going to get out of the way and you're going to hand the other professionals. I have to wait for this motorcycle pass. After you've done those things, you get out of the way and you look and you listen to what's happening, basically. You listen to see what do the physicians and the nurses need, and be there and know what those items that they need look like and hand them over. For people to have to not run around is the best thing in a trauma situation. You want to assess the patient and get them stabilized as soon as possible. And so because you're not a licensed person as a patient care associate or patient care tech, the best that you can do in that situation is just get the vitals, shout them out. The person that's doing the scribing will put it in as long as you are clear and communicating enough. And then after that, your role is just to be a passer. And it's actually super helpful because you never know what's going to happen, and having the right equipment is essential. You can't do anything without equipment. So know where all the equipment is and start handing it over. Start handing and anticipate. After you're in so many traumas and you see different kinds of traumas, you'll see like what's going to be required. And you'll be able to be more helpful. When you don't know as much, you're a lot more dangerous being right in the middle and like looking around and trying to ask questions. This is not the time to ask questions as a patient care associate. On other floors or on other units when there's downtime, 100% okay to ask questions, or like after an event has happened, definitely ask questions. That's how you get better. But in the middle of a situation, it's a wrap. And people will yell at you because tensions are high when you want to do a good job and you want to do a good job fast. So don't be that person that's in the way. Yeah, so let's move on. The other area that you can work in outside of the emergency department is the ICUs. ICUs, I think, are lovely because as a patient care associate, you're not responsible for much, which means that you can observe a lot more. So if you're there to learn, if you're there to see how things really work or how patient outcomes can be bettered, this is a great place to learn because there's so much fancy equipment in ICUs that you're not like qualified to use yet, but you get to be around it, you get to see it, you get to see how it works, you can ask a lot of questions about it, and you'll be there to do I's and O's, that's like kind of the most big task that you have. I's and O's, the input and output. So when someone's intubated and they have been in like a really bad accident and they are in any kind of critical care situation where they're not fully conscious, they're gonna have a series of either Foley's, rectal tubes, like nasogastric tubes. There's also, if they have wounds as well as being incapacitated, they will have drains for their wounds. They may have a chest drain, they may have something called a JP drain. There's all kinds of drains that you can have. There's all kinds of tubes that can be put into the several holes that people have. So there are machines that cycle blood, machines that keep the heart pumping, there are machines that keep the lungs working. You can experience a lot of things. Your main role would be to monitor the vital signs and make sure they're in. And a lot of ICUs, at least the ICUs where I work, the vitals will be cycling, so there's already equipment hooked up to the patient to where it's monitoring it on a routine basis and it has been scheduled. You may have to go in there and take a temperature, or if they have a rectal tube or a rectal temperature being taken, then you wouldn't have to take it. But what you would do is help them with turns. So people that are in critical care usually can't move by themselves. And you don't want them to get bed sores or pressure sores. You don't want any skin breakdown. So, skin breakdown leads to infection. It's so many kinds of issues. It's the largest organ on your body is on the outside of you, your skin, and we really have to take care of that in the hospital, especially. And especially when you're in critical care and you can't move for yourself. So we call this Q2 turn. So anytime you hear a nurse saying Q, it means however long. And so Q2, every 2 hours you would want to turn the patient. And so a patient may be hooked up to a lot of things, and so you would not do it by yourself necessarily. You may be able to, but most patients are, especially when they're hooked up to so many things, are not easy to move by themselves. So you would work on a team with another patient care associate, with a nurse, with a team of nurses, and you guys would readjust the patient, get them comfortable. You're doing a lot of comfort care in that situation, doing some oral care there, so they can't brush their teeth because they can't move their arms and things like that. And so you'll be doing that kind of a thing. There's suction because oral secretions definitely get produced under certain medications that are given when you're in critical care. And so that's another thing that you would see. Lots of secretions. So if you're not a secretions person, like if you can't handle it but you still would be like you're still interested in patient care, then the ICU might not be for you because it's literally all secretions of all the orifices. So that's your main role there as a patient care associate. And when you become a nurse, obviously you have like lots more roles. And the other main role there is blood glucose checks. Usually people that are incapacitated and intubated and things like that are not eating, and so if they're not eating, they're getting a feeding tube. If they're getting a feeding tube, then we need to be monitoring their glucose levels. And so that's going to be one of like the main roles that you have. Is it's depends on what other medications and things are going on, but I've seen everything from every 1 hour, every 2 hours, every 6 hours. Every 6 hours is super common. Every 1 hour, it depends on the situation, and you'll learn the situations when you're a patient care associate, and I think that that is like from experience, and I think that is just really awesome that you start to figure out what drugs and which diagnoses go with what kinds of care. And so talking about different kinds of care, we're going to move to Med-Surg. Med-Surg is literally everything that's not critical goes to Med-Surg. So it's the patient population is just really interesting. I found that a lot of patients that are what they call repeat customers are always coming to the hospital. Some part of what is wrong with them physically has a psych component to it. And so they can't take care of themselves because their mind isn't working correctly. And there's so many kind of different ways that's possible. And so usually patients that have some sort of psychological issue, when they do get a physical issue and do get sick, they have a hard time staying well. And it's really sad, but it's true. There's a spectrum. You're not going to be able to tell that with every single patient, but if you look at the chart, you can see, oh, okay, schizophrenia, this person has dealt with homelessness for a really long time. So you'll be experiencing a lot of people trying to tell you their story. And there's a little bit more time for it in Med-Surg, but there's also not. This is the place where you're going to have the most patients assigned to you. And your main roles are going to be to get their vitals, get their eyes and nose, help them with their daily cares. It's going to be all of it, and the labs. I work night shifts, so every night, if I'm working on a Med-Surg floor, I'm taking somebody's blood, and I'm putting it in a tube and sending it down to be read. And there's several different kinds of tests that are done all the time, but the routine ones that they're doing are to compare day to day to see if someone is getting better. So there's lots of blood tests that are being done, and that's my favorite part of the night. So if you love or are interested in phlebotomy, I would say definitely Med-Surg is the place to get better at it, or in the emergency department, because we'll be doing so many of them. The other thing about Med-Surg is you'll see wounds, you'll see burns. Then there's the geriatric population that has Med-Surg issues. So they have liver disease, renal disease, there's some heart disease. You could have a heart disease history, but that's not why you're there today. You may have fallen and hit your hip, or you may have a fracture, some kind of immunocompromised situation. You're going to be there for alcohol withdrawal, like I said, the patient could be there because they have some sort of metabolic syndrome happening. They've got some sort of something's wrong in their blood levels, and they're really deficient in something. We're not sure what. Maybe they're really dehydrated. So all kinds of things can happen as far as why people would be in Med-Surg, and so that means that the way that you interact with your patients is going to be varied. You have less time with each patient, but some patients are more needy as far as like needing attention or needing help with their daily care with like brushing their teeth and with eating, things like that. And so you have to be flexible. That's what I'm trying to get at. You have to be super flexible when you're working on Med-Surg, and you have to be fast. It depends on the hospital and their policies, but you can be assigned from like 6 to 12 patients, and depending on what that patient population needs, that could be pretty heavy or pretty light. So then the last place that you work is rehab. We don't work with the physical therapists themselves, but we do help with daily cares outside of physical therapy and occupational therapy. And if they have an order that they're supposed to be doing, you know, everything with their right hand to this level, like, you're there to monitor them and to help them with when they struggle, but it's about getting them rehabilitated and getting them better. So it's a fun experience. It's a different experience than ADLs with people that are in the Med-Surg side. In the Med-Surg side, they do get physical therapy as well, but it's definitely not as extensive and it's not as prescriptive either. So in the rehabilitation areas, it's really similar to Med-Surg. There's just more equipment for different types of injuries and different levels of ability. So there's just more technology as far as and more, yeah, there's more technology as far as the physical component. So there's more tools to help you with lifting and turning and moving a patient around, and there's more space for patients to be able to do things themselves. And so the rooms are a lot bigger. They're like singles, and there's a lot of cool ergonomic equipment. So if you're interested in ergonomic equipment and like seeing what's going on with rehab, it's a great place to be. The last assignment type that you can have as a patient care associate would be sit cases. So sometimes there are patients that come in and they have, let's say they're really dehydrated, they haven't been taking care of themselves, and their body is in a decline state. That can have so many different kinds of symptoms. Well, let's say one of the reasons why their body may be in this state is because they are just now experiencing like signs of dementia, or they are dealing with a psychotic episode, or they are feeling suicidal. They're at risk for self-harm, basically. If they're not oriented to self, or they're not oriented to others or place or time, they may get confused and think and sometimes patients, yeah, they get confused. They think they're in a different time, they think they're in a different place, they think someone's attacking them. I know there's the term pleasantly confused, where, you know, they just will have the same conversation with you over and over again and call you sweetie and like are just as happy as can be. But there's the other side of having psych patients that aren't able to care for themselves anymore, and they can become violent, they can be paranoid, etc. And so those patients that are at risk for self-harm have sitters. And as a float pool personnel, you're going to any area that has dire need or is in the most need at time. And so patients that need one-on-one care, that's where float pool staff goes first. And so I think like half the year or half your shifts usually end up being, at least at the hospital that I work at, sick cases, or a part of sick cases. So you might go into work one day and 4 hours or 8 hours of your 12-hour shift will be with one patient only, and that's because they are not in their right mind. I recently was in a sick case where a patient needed to be on a machine to breathe, but they weren't oriented and they weren't oriented to where they were. So they were fighting and trying to pull off the oxygen constantly. But without the oxygen, they wouldn't be able to breathe. And so I was there to be with that patient, remind them where they were, and keep them from removing their IV that was keeping them alive because they needed certain medications and hydration via IV. And so to keep them from pulling those out, pulling away the oxygen, you can't just leave a person like that has those tendencies alone. You come back, their central line will be gone. I mean, they'll be bleeding out. It can happen. Definitely I've heard cases where, let's say a patient had a femoral line, and they weren't in their right mind, and they felt something on their leg, and they just pulled it. They're bleeding out, they needed to get a blood transfusion. This really happened. But this was because they did not have a sitter. And so that can go all kinds of ways legally, you know what I mean? So sitting cases, they can be at times taxing because you're just sitting there or just standing there at the bedside, but you have to keep your eyes open and you have to know what you're looking for, and you have to learn people's patterns. If you learn their patterns, you can anticipate before they are about to self-harm and you can stop them from doing so. But then you also have to keep yourself safe at the same time, and so learning really good communication techniques and being emotionally aware and knowing when to call for help and knowing what your resources are is so important. Also, sitting cases are a great opportunity to figure out when someone is going into decline, and so you'll see that the patients that are in that case, they are maybe at risk for not protecting their airway or their heart to not be working correctly. So the vitals are very vital in that situation. You want to be paying attention. If you see something if you see the patient changing color or anything like that, you need to do their vitals really quickly and call their nurse. It's a role that can be really helpful to a patient's outcome if you let it be. It can also be frustrating if you're with a patient that is really violent or they are really scared and they are acting out. It can be a lot of energy given, but it's an important role. So that's the other place you can go as a float pool person. The pace of your work, depending on where you are, so at the emergency department, it can be go, 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 or it can be a slow day. And so it depends on which area of the emergency department you're in, how fast it's gonna go. Usually in the psych area, you're sitting down a lot because they're not needing vitals as frequently because nothing life-threatening is happening right now, except for obviously self-harm, which you would be preventing. And so in the critical care unit, though, your flow is pretty even. So because you have so many patients that you're working with, and all of them need to be turned, and all of them need their glucose checked, and all of them need their eyes and nose done, it's kind of like once you get to like each and every room, you'll be back at like, once you get done with the last room, you're back on another cycle and start over again. But it's evenly spaced out to where you're not rushing, you have time in between, you can learn in each room, you can have time to read the chart if you would like to learn more about the patient and their illness. The pace is slow but even. The pace in Med-Surg, it depends on the time you come in of the day. There are chunks of the day, there are certain 4-hour blocks of the day, like from 7 to 11 in the morning and 7 to 11 at night, where it's extremely busy and you're behind right when you start. Like, there's just no way to be caught up. There's too many things going on with the patient's care, and you're responsible for so many people, so it's just a mad dash, and you're always it's hard to stay on top of it unless you're super organized. And being in a float pool position, it's harder because you don't know the patients, you didn't see them yesterday, you are seeing somebody new every single day, and so you don't know what to expect, and you don't know how to prepare as well as you would if you were consistently always on that unit. And you don't always know where everything is on a unit, and so being in Med-Surg and having new admissions coming or people leaving and discharging, and then someone could be coding. You have to be really flexible and really open-minded, and and know that how prepared you can be, and just be that prepared, and everything else you have to roll with it. In the sick cases, you have a lot of time to get to figure out how to understand someone's baseline and get them there if they're going away from it. Learn some really cool communication techniques. I've definitely enjoyed sick cases where a patient had a communication barrier, like they were deaf or they spoke another language. I got to learn a lot about how to work with other people, and so that's why I've enjoyed in sick cases. But that was a lot. There's a lot of duties that you can get to see as a patient care tech, and if you want to know why I chose to become a patient care tech in the float pool, then stay tuned for my next video, and I'm glad that you guys are here, and I'll see you guys in the next one.